Anyway, my name is Jose Maldonado. I'm the chief of the Division of Medical Psychiatry and the medical director of critical care psychiatry at Stanford University. And I organize this workshop, symposia, whatever they call it these days. I'm really excited about this presentation because A, because all of you are here, but B, because I have been able to pull together two of my favorite female researchers that I know and that I have been working with for many years in different capacities, and suddenly like all the stars align and we're all together on the same place. Especially Dr. Heidi Smith, who, if this is your first meeting here, of course, you cannot go to a Delirium meeting and not see Dr. Heidi Smith.
Although I would not be there.
Anyway, or as I like to call her, the queen of delirium. No, I mean, everything I know about pediatric delirium comes from her. She has been very generous and invited me to be on her advisory panel. So I'm learning a lot from her in that capacity. And then when I was a very young, early researcher, Chicky Monkey, the board of directors of the American Delirium Society invited me to give a plenary talk on the pathophysiology of delirium. So have you ever seen my very complicated drawing for delirium? That came from that talk. And Jesny Alishi, who is one of our speakers, was a member of the board of directors. And I realized after I got invited for dinner that night that it was a trap. And I have been a member of the board of directors since then. And it has been a wonderful experience. It has grown from like 10 of us meeting in different airports throughout the United States to having our own meeting with hundreds of people. And it's a very, very multidisciplinary meeting. So not just psychiatrists, but nurses, neurologists, critical care physicians, etc. And then finally, but not least, Dr. Matthew Gunther was my fellow, talking about Chicky Monkeys. He was my fellow until last June, and now he's an attending, and he has demonstrated to be a wonderful researcher and speaker and presenter, and he is going to do our first presentation. So we're going to have all four speakers do their presentations, and then we're going to hold all the questions at the end because there might be overlap going back and forth. And since we're talking, as I said on my previous slides, and we're talking about delirium throughout the lifespan, it might very well be that we want to address the same question about, for example, diagnosis in all three at the same time. So without further ado, Dr. Matthew Gunther.
All righty. Thank you, Dr. Maldonado. I appreciate it. Hi, everybody. My name's Matt. So I'm going to be talking about delirium by the numbers, really giving a gross overview of the incidence of delirium, as well as the burden that delirium affects our society in terms of the financial and burden, as well as other health outcomes. And lastly, some about the social determinants of health as it relates to delirium. And I have no disclosures. So we couldn't start with briefly defining delirium. I don't want to spend too much time on this slide, but I think we're all very familiar with the kind of disturbance in attention and arousal, as well as the cognitive symptoms that come along with delirium. But I really wanted to point out that there are other facets of this that will come up and factors when thinking about a delirium diagnosis, including the emotional dysregulation piece, which can often present as anxiety or fear, irritability, the psychomotor disturbance, and of course, the circadian rhythm disruption. So this slide, I think the main take-home point I would mention here is the fact that the incidence of delirium is not large just in inpatient acute care settings, but also kind of goes across the healthcare settings that our patients are in, including nursing homes, outpatient care, et cetera. And starting with the upper left there in terms of pediatric delirium, you can see how quite high that incidence can be in the ICU setting, upwards to 60%. And then as we shift towards the adult side, looking at the emergency room setting, the medical surgical wards, maybe around 40%, and then into the ICU, it skyrockets to 80-some%. So really pretty dramatic in terms of how high the incidence can be. Also at end of life in the elderly, thinking about terminal delirium, where there are days, weeks, or hours, days, weeks in terms of one's end of life, that also delirium can be quite high, up to 88, 90%. Putting this in sort of a visual representation in the palliative care literature in particular, this red box here is looking at, again, end of life, showing just how high and how prevalent it is, upwards of 90%. But as you can see across multiple healthcare domains, including in outpatient care, it remains a very big issue. Okay, financial burden. I think the red number speaks for itself. By comparison, thinking about other impacts that the healthcare system faces in terms of high cost conditions. So for example, hip fractures in this number by comparison are 6 billion compared to 150 billion. Diabetes across the United States in terms of that figure is 250 billion. So the entity of delirium is highly costly, which leads to a lot of efforts in terms of research. Breaking that down a little bit, you can see on the pediatric and adult side there a few more numbers. When we think about PICU admissions, there's an 85% increase in terms of cost, $14,000 per admission, and that totals to be about $500 million, which is pretty large. On the adult side, I think one thing to take home in terms of the cost is that as delirium severity increases, so does the cost to the system. And also delirium is not just a factor in terms of cost in the index hospitalization, but also rehospitalizations and rehabilitation. So it really does lead to quite an increased burden to the system across one's medical care. Outcomes. So certainly increased morbidity and mortality, and that's seen again across the lifespan. On the pediatric side, both in hospital and outside of hospital, there's increased morbidity and mortality, even looking at 6 months, 3 years along the way, a 10% increase. On the adult side, there's an increased mortality in the first 30 days, but also at 12 months, and overall the increased risk of death compared to controls. One area of study in delirium research is healthcare utilization, in particular looking at delirium management sort of studies and how we can lower the length of stay. And a lot of that evidence shows that there is an increased length of stay across the lifespan in terms of when someone is diagnosed with delirium. That can then lead to further rates of institutionalization in terms of nursing facilities and long-term care, in which delirium is also very prevalent. So I think this is a big area of study as to how to lower that length of stay and sort of reduce that impact moving forward. We can't talk about delirium if we don't talk about cognition, not only sort of premorbid cognitive functioning and how that can play a role in terms of the development of delirium, but also the cognitive impacts that one has when you do experience delirium in the hospital or another setting. On the pediatric side, there is an association with cognitive impairment, kind of 6% increase with each day of delirium in this one large study. On the adult side, there's some evidence that's looking not only at cognitive impairment, but the development of major neurocognitive disorder and dementias after one does have delirium. And you can see that there's an increased risk, 62.5% versus 8%, so very high. There is actually a new study that came out in JAMA in 2023, the SAGES study. Dr. Oldham did a great dissection of that on one of the Academy webinars that looks at 72 months in people that have had delirium in an elective surgery. There were 560 folks, a quarter of them developed delirium, and they followed them for 72 months, and there was a 40% increased likelihood in terms of the acceleration of cognitive impairment in that study. This is a nice figure from a 2022 study looking at kind of one's cognitive reserve, intelligence, and cognitive functioning before experiencing delirium. And this looked at those who were coming in for an elective surgery, age 70 above. And you can see that there was, well, maybe not in this graph, but there was evidence that premorbid cognitive functioning was somewhat protective, meaning the higher cognitive reserve you had in terms of educational ability, et cetera, was protective in terms of incidence and severity. But then if one did experience a higher severity delirium episode, there was quite a precipitous drop compared to the other folks in terms of baseline cognition over the course of 2 years. So pretty impressive. Shifting a little bit to social determinants of health. As a reminder, these are the constellation of economic, psychosocial, and environmental factors present throughout a person's life that influence one's health. And I think we're very used to discussing medical comorbidities and things like that related to delirium development and the impacts. But we also can't forget that there's a lot in the social determinants of health realm that can affect that. More than just age, but also racial ethnic disparities, structural inequalities as well. There's some growing literature in this. In 2020, this group from Arias et al. Looked at neighborhood level characteristics using a metric to look at the level of socioeconomic disadvantage in neighborhood communities. And they found, looking at the delirium severity on the y-axis and then the level of socioeconomic disadvantage on the x-axis, that it was correlated with increasing delirium severity. So some things that we have to address from a structural level, certainly. And this spurred on a kind of framework for looking at the social determinants of health as it pertains to delirium. And there are kind of multiple factors here, but some things that I think stand out in the blue, for example, social capital. So we do know that individuals who are socially isolated and have limited family support, et cetera, are at increased risk for dementia, and that then translates into increased risk for delirium as well. We talk about age, we talk about parental education, immigration experience. So many factors that we have to address as a society, in particular, if we're thinking about healthcare utilization and costs, certainly, but the cognitive outcomes and other factors that relate to having a delirium diagnosis. So a lot to think about and ways that we can influence delirium, but hopefully that gives you a sense kind of how delirium affects society on many levels. And that is it for my part. Thank you. And next up is Dr. Heidi Smith.
Well, thank you again for inviting me to Austin. And I did really enjoy dinner, by the way. So I do not have any disclosures. And our goals for today are really to touch on epidemiology of delirium in pediatric patients, which Matt already went through some things, so that's perfect. We'll highlight current recommendations for delirium screening, also discuss management strategies, and then how we continue our partnership in moving forward with really assessing, preventing, and managing delirium in children. So we will highlight some of the recommendations from the Society of Critical Care Medicine PEDS Pandem guidelines. This task force included 29 multidisciplinary experts in the care of critically ill children. And we focused on questions regarding the prevention and management of pain, agitation, neuromuscular blockade, delirium, in critically ill children, and then going on to consider things such as the ICU environment and early mobility. We will focus on, obviously, recommendations and data regarding delirium today. So we already touched upon prevalence of delirium, and I think this wide range, when you look at the last 2 decades of pediatric literature, this wide range in prevalence really represents 2 phases. Early on, where much of the literature was from the psychiatrists in the room, where you were getting consulted on patients with historically ICU psychosis, those hyperactive symptoms that became very disruptive to patients based on either safety of the child or disruption of the ICU environment per se. And so how or what were they supposed to do with those patients? And so early on, prevalence of hyperactive delirium, which is what we really were seeing, was more that range of that 5 to 15%. It was really with the creation, validation, and then implementation on large scale of delirium screening in the ICU that then the full picture of delirium and what it looked like in children became more evident, focusing on those hypoactive and mixed subtypes, which are by far much more common than the hyperactive subtype in the ICU, albeit much more difficult to recognize if you're not screening. Risk factors, we continue to elucidate those that are most important regarding delirium in the pediatric population, but by far younger age, it is consistently demonstrated in large prospective cohort studies to hold a significant risk for patients developing delirium. Also, baseline neurodevelopmental delay carries a 3 times higher risk of delirium in the critical care setting compared to patients with normal neurodevelopment at baseline. Poor nutritional status, cyanotic heart disease, another risk factor. Precipitating factors, a lot of it coalesces around the critical illness itself and other aspects to that critical illness, such as requirement of mechanical ventilation, and also for our cardiac patients, how long they require being on cardiopulmonary bypass prior to coming to the ICU. But the treatment-related factors or iatrogenic factors really are the onus of us, which really has a lot to do with sedation. And both from choice of sedation, so known dose-related response of benzodiazepines to risk of delirium, but also depth of sedation, which is going to be one of my major messages here. There's not one culprit in the sedation world that potentially increases risk of delirium. It is the culture in the pediatric ICU of, albeit many times, over-sedation, regardless of the drug, that also increases risk of delirium, and we can't ignore that, even though we want to. Pediatric literature does a pretty good job of describing in-hospital outcomes, such as, again, prolonged ICU and hospital length of stay, also prolonged duration of mechanical ventilation. We talked about cost, which kind of goes along with those things. Interestingly, mortality and the relationship between delirium is not exactly clear. There was a large longitudinal study of around 1,500 patients that showed that delirium was a very strong predictor of mortality. And yet a follow-up retrospective study of over 2,500 patients did not elucidate that particular relationship. And so in addition to mortality, there are other major knowledge gaps, such as delirium and association with long-term cognitive impairment, attention deficits, and post-traumatic stress in both the patient and the parents. We still need a lot of studying to do. So we have a long ways to go. So in screening, the task force actually looked at 5 different tools. We ended up recommending 2, the confusion assessment method for pediatrics and also the Cornell assessment of pediatric delirium. Those decisions were based on the robustness of the validation methods that were used for both of these tools, in addition of the use of a reference standard, which is our child and adolescent psychiatrist, and also the size of the studies. So just briefly, the confusion assessment method for pediatrics was adapted from the adult CAM-ICU. It maintained that hierarchical assessment strategy where we put those cardinal features, DSM criteria, first and required for delirium presence. So feature 1 and feature 2. So acute change or fluctuating course of mental status and also inattention. Then feature 3 and feature 4, altered level of consciousness in the moment and disorganized thinking, only one of those are required. Those are bolstering evidence that feature 1 and feature 2 truly are due to delirium. When we considered assessment of delirium in children, we also had to consider developmental age and the changes of both cognition and language that can actually create a lot of barriers as you continue to decrease in age. Also, the presence of psychomotor retardation, agitation, and anxiety in children when they're hospitalized, and even regression of previously learned skills, particularly in critically ill pediatric patients. Our inattentive assessment in children did not really change that much from adults. In children aged 5 years of age and older, developmentally also at least 5 years of age, we use the PCAM-ICU. We still use the Vigilance A. So squeeze my hand when I say the letter A, then follows 10-letter sequence, about 10 seconds assessing of that sustained attention. In feature 4, we had to alter it a little bit because questions such as, does a stone float on water, is not developmentally appropriate for a 5-year-old to answer. So we transitioned to questions such as, does a bird fly? Is ice cream hot? Okay. We validated the PCAM-ICU against our reference standard, child and adolescent psychiatrists, and the tool performed extremely well with a high specificity and sensitivity. We then further adapted the PCAM-ICU to the preschool CAM-ICU. We then again had to adapt feature 2, inattention, and feature 4, the disorganized brain, because now we were dealing with neonates, young infants, and preschool children. I can't ask them to squeeze my hand. So how am I going to assess for inattention? And so we transition to very bold colored elementary pictures and also reflective cards. Why? If you look at almost any children's book and you open it up, what's there? A reflective surface, because they love looking at themselves. And so we again had to recognize that when we're assessing inattention in infants and younger children, there's a complexity to arousal, right? We know that they have a higher percentage of slow wave or deep sleep. They have postprandial sedation, which we also discussed last night that we do too. But nonetheless, after a gavage feeding, do you know how difficult, or if you were to go in to assess an arousal level of an infant, their arousal level would be consistent with coma. So they are difficult to arouse even to touch. So do you think that's a good time to go in and assess for delirium? Probably not, because it doesn't reflect truly what's going on with the brain. And so timing is important. And that's why, particularly with neonates and young infants, the nurse has to be involved, because the timing is important to get to the truth of whether or not a patient truly has delirium or not. Feature 4 had to transition again to dysregulated systems or the disorganized brain. I can't ask the infant a question, but I can look for dysregulation by looking at whether or not they have a sleep-wake cycle disturbance, or whether there's unawareness of surroundings, unawareness to a toy or a blankie that they usually utilize, or even unawareness to a mother's face. Okay, inconsolability, that's beyond already treating for pain. They are not reactive appropriate to normal comforting measures, or they can have repeated kind of grunting or moaning that again is inappropriate. We also believe that it was extremely important to validate this tool in a staged approach, because again, we needed to make sure our reference standard felt comfortable in assessing for delirium at the same time if we're wanting the tool to tell the truth. So we first validated the preschool CAM ICU in age 6 months to 5 years. And then we subsequently separately validated it in neonates to 6 months of age. And again, what's so amazing, we let the data drive what attention level was necessary. And what I find totally amazing, and we'll look at this in just a second, is that the brain wants to interact with the environment. It doesn't take a lot to see that interaction. And so whether or not it's a neonate, an infant, a school-age child, and even an adolescent, about 8 seconds of attention is what's needed. So when we do our inattentive assessments, if they make 3 or more errors, then they are inattentive. And we didn't come up with that. We, again, compared what levels of attention our patients had compared to, again, which patients our reference standard said had delirium. So it's quite amazing. So I wanted to quickly just show you what this inattention assessment looks like in our infants. This first video is a chronic patient who was trached and home ventilated, but came in with pneumonia, had recovered and was getting ready to go home. But I wanted to show you, we initially looked at what was necessary for attention. Was it just looking at the picture, tracking, reaching out like they're naturally doing? And really, it only required eye contact.
Look at the
Of
picture.
8 pictures. Don't know why it's stopping here. I'm going to quickly go into, I just wanted to show you the rest of this video. I'm not sure why it's not working. Here, I'll just go to the direct file here. Okay. And then we later, just gonna forward this, sorry. Okay, I'll come back to the video. I'm trying to do it. For some reason, it's not. I'll come back to it. We'll try it again. So sorry about this. We thought we had this figured out. It's not even wanting to. It is.
Room full of strange.
Okay. IT person, I am not. Showing up there, okay. I'll try this one more time, and if it doesn't work, then we'll just continue on.
You see the mirror?
Sorry to show this part again. I would really like
Look at the
for you to
picture.
see the second half of this video. But you have to
There you
admit,
are,
pediatrics
yeah.
is pretty awesome. So we like seeing healthy children.
You see the elephant?
So the second video will start
Look
with
at the
another
picture.
patient, a cardiac patient. Oh, it's not going to do it. Okay, so I'll see if I can't. I don't know why it actually, there we go. Okay. So it was actually this presentation, a presentation similar to this with the preschool CAM ICU that I was giving at the American Delirium Society. And there was an amazing audience of mostly psychiatrists and geriatricians. And what was amazing is that there became this collaboration because we had to work through making sure that our inattention assessment separated cognition from attention. They saw an opportunity to do the same thing, particularly in their patients with dementia. So when you're doing your attention assessment in patients with dementia, particularly severe dementia, what degree of cognition are you actually assessing in that attentive screen instead of just attention alone? And so they actually took the preschool CAM ICU, including the cards, and that became their attention assessment. And that is the 4DSD that was validated by Alessandro Morandi and then published in JAMDA. The task force also, as I said, recommended the CAPD. And so this is more of an observational tool where the nurse will use the Likert scale to assess for 8 domains at the end of a shift: eye contact, purposeful action, inconsolability, unawareness of surroundings, restlessness, communication of needs, underactivity while awake, and prolonged response to inattention. I just wanted to share quickly some of the barriers that we still struggle with in the ICU regarding monitoring. And I think the first and most important one is that recognition is not consistent without a tool. There is still a struggle with many clinicians thinking that arousal equates delirium. So if you have a patient who is inappropriately sedate or a patient who is inappropriately agitated, that those patients have delirium, okay? But that's just not the truth. You do not know if a patient has delirium, and I know I'm preaching to the choir, until you walk up to that patient and knock at the door. And that knocking is your delirium assessment. That is content of consciousness. And so our struggle is, again, saying, look, it's important to assess for arousal, but it is even more important to go that next step and use a valid tool to assess for delirium. Is your patient actually home? Now, I can understand how confusing it gets because delirium is not simple. We like a disease and the constellation of symptoms that go along with that disease process. Delirium, brain is complex, and therefore it is understandable that delirium then manifesting with hypoactive symptoms, hyperactive symptoms, deciding to flip-flop on the same day from hypoactive to hyperactive. That constellation of symptoms becomes confusing, that's manifestation of this syndrome. That is not actually the criteria for disease, criteria for diagnosis. And so again, opportunities for education. The other issues for the bedside nurse is that, hey, you're going to educate me. I'm going to do these assessments at the bedside, and then I don't see a change in the plan. Now, some of that is that sometimes the team doesn't listen to the bedside nurse, and that happens. But the other piece to this is that the brain and the way that we treat it, I would argue delirium treatment is not easy. And in fact, I don't believe there is a specific drug we can give to make the delirium go away, right? And so it becomes more like the kidney. It's important to know that the kidney is not working, but the critical illness itself is causing most of the disease. And until that disease process goes away, the kidney many times can't recover. So what are we doing? We're trying to mitigate harm to that kidney until the critical illness gets better. And in some ways, that's what we're doing with delirium. And so again, understanding that sometimes what it looks like is that the team's not doing something, that recognition that delirium is present is still important. It also reflects on our behavior of what we're doing in the ICU regarding sedation. Understandably, the nurses don't want us to stop all the sedatives, and that's not our goal, okay? But is it about our comfort or about our patients doing better? And that's, again, something that we have to keep aligned. Sometimes the nurses think that delirium, and this was more early on, that it meant the patient was crazy. They didn't know how to talk to the family about delirium. That's become better over time, but nonetheless, it still highlights the importance of education. So the task force looked at 3 general questions: what non-pharmacologic and pharmacologic strategies reduce the incidence and or decrease the duration or severity of delirium. And we also looked at whether or not haloperidol or atypical antipsychotics could reduce the occurrence rate or decrease duration or severity of delirium. And what we found in the literature is that although we believe that environmental impact is considerable on our patients, unfortunately, our literature just doesn't support it. So it highlights again those areas where we do a lot, but we don't always publish, and those publications are so important. So we believe modifications to the ICU should make a difference: artificial light, minimizing noise, bundling care, and producing a schedule for our patients. And most recently, in the last couple of years, there's been more data out about noise. So we think that there's a lot to learn, but unfortunately, at the time that our clinical guidelines came out, we just didn't have the data to support specific recommendations. Now, as pediatrician, cognitive stimulation, school, physical activity, important in healthy kids. Why would it not be in sick children, right? And that hence that early mobility piece. And then family presence. We've had families at the bedside since the first child comes into the ICU. But presence is not the same as activity or involvement. And so we'll talk about that in a minute. Prevention really falls to the ICU. We use an acronym called BRAIN MAPS to constantly help us cycle through differentials when a patient has transitioned from a negative to a positive screen. So hypoxia, removing or reducing deliriogenic drugs, the ICU atmosphere or environment, immobilization, new infection, new organ dysfunction, metabolic disturbances. And the 3 that we have a really hard time about is having patients more awake with better pain control and less sedation. We'll talk about that. So this word is the bane of our existence in the ICU, okay? And unfortunately, it is not related to just delirium. Agitation can be a symptom of pain, anxiety, fear, iatrogenic withdrawal, and delirium. And not only can it be involved with all of these different things, but the question becomes, do you have to treat agitation? We usually do treat agitation, albeit we over-treat agitation. Again, sometimes it's necessary. Patient ventilator synchrony, the patient's uncomfortable, they are not safe. We need to treat agitation. But there's many opportunities for decreasing that ramped up treatment that we don't always do, because I don't want to say we get lazy, but we're busy. There's other things to do, other things to think about. And so sometimes when a patient is quiet, they're a good patient, they can be paired. And so that also impacts our patient care in the ICU. But we try to focus on 3 other questions to help guide whether or not we should treat agitation or to what degree. So where is my patient now? What is their arousal? What is their pain scores? What do they or don't they have delirium? What has been their screening trend? What is their current level of critical illness? Well, where are they going? Can we start weaning them from ventilation? Are we decreasing vasoactives? If we are, then how do we get them there? And some of that will drive whether or not we are aggressive about management of agitation versus not. That doesn't mean we're always not focused on pain. We are. But a lot of times you are treating pain and the agitation persists. So what are we doing then? Well, we have to take what we know. Sedatives are associated with delirium, but pediatric patient needs are different. and choice of sedation, although we thought we found a perfect drug in dexmedetomidine. But the problem is when you take a good drug with minimal side effects and you don't change the way in which you are utilizing that drug. So forcing that drug to produce a level of sedation consistent with deep sedation near coma, and you keep a child there for 5-6 days, are you surprised that when you lift that drug, that the patient has acute brain dysfunction and also has withdrawal symptoms from dexmedetomidine? So hence, yes, drug choice may be important. Benzos may have a greater association with delirium at lower doses, but that doesn't mean that every patient that receives benzodiazepine ends up having delirium. So it then becomes our culture. So what do? We need to find more creative ways to help push patients forward, decrease or avoid exposure to sedatives, and really change the culture in which we're utilizing that as well. The A-to-F bundle is one way that we've tried to do that. And this is a way in which we think about brain health in the same setting as the critical illness. So when we have our interdisciplinary team there on rounds, we're talking about assessment and prevention and management of pain. At the same time as we're talking about how are we going to move these patients forward regarding ventilation. Thinking about, well, if that's the case or whatever our plan is, then what is going to be our choice of analgesia and sedation? Well, that partially takes into consideration, are they screening positive or negative for delirium? And what are those particular risk factors for this particular patient? Do we need to really focus on non-pharmacologic interventions to make sure that we help this patient that was on bypass for 2 hours the other day to prevent them from transitioning to a positive assessment? Well, one way we can do that is by allowing them to be more awake, get them mobilized. Doesn't mean getting up and walking around all the time, but maybe we get them up to a bouncer. Maybe we allow the family to hold them. Maybe we allow PT/OT to actually do their jobs. And then family engagement, not just presence, not just information gathering, but utilization as a patient advocate and also involved in patient care at the bedside. So this really brings us back around to pharmacologic management of delirium. And I would just say that I hope we agree that there's no drug that cures delirium. And that's a really important message for the intensive care unit to hear. We'll talk about why that is. But we preach that the primary goal is to treat underlying causes first. And that brings us back to that brain maps, thinking about all of those clinical things that can lead to a sick brain. Really transitioning from negative to positive. But the secondary goal is also safety and mitigation of severe manifestations. And we recognize that sometimes there is a role for other types of medications to help with that. And that is where haloperidol and atypical antipsychotics might come into play. The pediatric literature involving administration of these medications largely are retrospective studies when we were looking at the literature for our task force, and also case studies and case reviews. And the key thing that came out of this is that when these were used, they did seem to decrease the severity of manifestations. The flip side of that is that when they were used, there actually were not significant side effects. There were a couple of cases of prolonged QTC, also extrapyramidal side effects, but with the discontinuation of the medication and sometimes some treatment of the extrapyramidal effects, there was no significant adverse events that related to the child. But we have to realize that this, again, is off-label for use by the FDA. And so when it came to our recommendations, we focused a lot on sedation. So which sedation, how much sedation? We could not suggest routine use of haloperidol or atypical antipsychotics for the prevention or decrease in duration of delirium, but we did recognize that there may be a role in use during refractory delirium for controlling some of those severe manifestations. But this is where we really need to meet in the middle and have consistency of messaging, I believe. We love our CLP teams coming to the bedside. And part of this I highlighted throughout. Education is so important. And education for the bedside nurses from you, and also to our medical team from you, is extremely important. We know that these tools that we are using are not perfect. We're not perfect. but we always want to come to the truth of what is happening to our patient. And so if there's opportunities for us to discuss what's going on with our patients and what you're seeing that we're not, it is important for us to know. The other piece to this is that I don't believe that protocols are perfect when it comes to delirium, because I don't think this is a one size fits all. There are personalized approaches to care that are key. We're learning more about from our CLP group, the importance of trauma at baseline. We don't ask about psychological trauma in the ICU. We should, but we don't consistently. And we're recognizing that that may also play a role in how this sick brain potentially can recover over time. And so there may be a plan that you see that we don't see that is important for that particular patient because of their history of trauma. And we want to know about that. We're going to ask a lot about sleep hygiene. And I know that sometimes we utilize atypicals and the different profiles that they have to help try to initiate some of that restructuring of sleep. But those drugs may not be perfect. There may be another drug that you think is more important to help with that. I think the other key thing to hear is that dexmedetomidine does not cause sleep. So we're trying different ways to cycle dexmedetomidine, but in a brain that is already sick and unable to get into REM sleep by itself, dexmedetomidine cannot cause sleep. At least I don't think the evidence shows that. I think it shows that it doesn't disrupt sleep to a significant degree when the healthy brain is already able to get there. So again, I think we have to take the data for what it is and try to find better plans for helping this sick brain get back in and readjust and get back to baseline. And iatrogenic withdrawal syndrome, I hope that we're assessing for that and doing a good job on that. But it's also important for you to call it out if we're not. And that may be part of what's driving some of the delirium, not all the time, but sometimes. And then use of adjuncts. We want to learn. We know that there's opportunities to use anti-epileptics, gabapentin, and sometimes alpha-2 agonists, if they're not always already used for our sedation, in order to tackle some of these severe manifestations that we're seeing. But I also think that it's important for you to know what the real question is. Sometimes you're being asked to come see a patient who is a difficult to sedate patient, who is already undergoing polypharmacy and still having severe agitation beyond that. In those particular patients who we're not able to make a move on because their lungs are still sick or their heart's still sick or they're still in septic shock, I encourage you to say yes to haloperidol. Why? Because we're still scared of it. We will not overuse it. We will use it when it's necessary. But by you saying no to us regarding atypicals, which honestly, we're not afraid of. And once we start it, we honestly kind of check this little box in our brain that we've got a delirium drug on board. So guess what? We don't have to do anymore. We don't have to worry about sedation because we're doing our job. So we have to be careful about if you feel like an atypical is appropriate. I would also suggest that you encourage us to make some significant moves on sedation. And if we're not ready to make that move, then maybe an atypical is not the right idea. So I think a good understanding of what is the expectation and what is the plan for treatment. I also think that a lot of children right now are continuing, once they get started on these medications, they continue on them outside of the ICU, even up to discharge to home. Some of those patients, it may be appropriate, particularly those patients with a history of trauma. But I still think that we need to do a better job of communicating between our teams about what really is the plan. Finally, I'll just kind of end with opportunities for ongoing collaboration. I think for many years, intensivists, we used to pat ourselves on the back if we could get a patient out of the ICU, breathing on their own, tolerating enteral feeds. It was like, we've done our job. But we also know because our mortality rate is less than 5%, our light at the end of the tunnel, which for us was discharge to home, was actually just the beginning of a very long recovery for our patients and families that we were not recognizing. And so a lot of this comes from a lack of functional recovery by the time that they're going home. And then there's this stalling of physical health recovery, emotional health recovery, cognitive health, and social health. These parents and patients are going through having pain, fear, anxiety, depression, leading to a very dysfunctional family unit. And all of this constellation of symptoms is post-intensive care syndrome, or PICS. And so we want to continue to work with you as an interdisciplinary team to continue to put this on our radar. Not that there aren't PICS-P clinics around, but they're not very common. And we really feel like working with you and collaborating with our medical team, it's really the only way that these patients are going to reclaim life from critical illness. So thank you so much for your attention.
Well, that's a difficult act to follow. You understand why I brought her all the way here from Nashville. So I'm going to kind of follow up on what Heidi was talking about and give you the grown-up side of the same presentation. So I do have a few disclosures, but don't pay attention to any of them. When things get dicey, I will point them out to you, but there are at least 3 companies there that I'm doing research with them, and I am talking about their products, so I will highlight that as we discuss, but the bulk of the conversation is not paid by any of them. I like to think about delirium in terms of systems, right? And, hypothesis of delirium that we published some years ago talk about the presence of what we call the predisposing factors of delirium, or the delirium substrate. These are the things that the patient bring with themselves when they come into the hospital or where they come in touch with us. And then to them, a number of precipitant functions, they get an infection, they get a trauma event, we operated on them purposely to do something. And the combination of those two, or one acting on the other, tends to lead to one of 2 pathways. In one of them, the one on the left, you see that there's a disruption of pathways that normally will communicate with each other. Think about when a patient becomes delirious. Some of them become hyperactive. Some of them become hypoactive. And the reason for that is which of those pathways is winning. So is the excitatory systems winning, and then you have hyperactive patient, and the inhibitory system is winning, you get a hypoactive patient. But then the other one has to do with which neurotransmitters are being represented in the behavior that you see from that patient. The combination of those two are going to lead what I like to call acute brain failure or delirium. I have to say that during my year as president of the American Delirium Society, I tried to change the name from delirium to acute brain failure. I thought it was a brilliant idea. My board did not agree. Anyway, so why should we care about delirium? Why is it that we're so passionate about delirium? I'm going to give you 7 good reasons to think about that. Number 1, as we saw from Dr. Smith, delirium is exceedingly common. And the other thing that you're going to see is that depending on how sick the patient is, it becomes increasingly more frequent. So when you look at the general hospital setting, you see incidence somewhere between single digits to about 20%. But as people move to the ICU, that incidence goes up somewhere between 60 and 85% of the population. The second one, also as mentioned by Heidi, is that many medical processes that our patients will be suffering are known to cause or predispose people to delirium, from an acute infectious state that then will prime those cells. So when the patient is re-exposed, we'll have a stronger effect or event. And then other things like hypoxygenation, whether that is because the patient is anemic or because they were in the operating room and somehow for some reason the patient got desaturated. But Also, as implied before, many of our treatments have been associated with a higher incidence of delirium. So Patrick and the Pinde show us that as we increase the amount of benzodiazepines that we're using in patients, the incidence of delirium tends to go higher. Dr. Smith herself replicated that study on patients and children, showing that the higher dose of benzodiazepines, higher the incidence of delirium. And then Breitbart and others have demonstrated that if benzos are bad, opiates are particularly worse, right? Now, not all opiates are created equal, and part of what we need to do with our colleagues in critical care is to find the best combination of medications, meaning which one are the least offensive. In fact, when you look at meta-analysis, you see that there are many things that can lead to delirium, some of which we can control, some of which we cannot. But the one that is the worst is something that we do because we have the power of the pen, right? We are the one who are prescribing the benzo, the opiate, the alpha-2, or something else that might lead to that. There are many, many, many factors in the hospital setting. This is particularly about ICU setting, but there are many, many, many factors that lead to delirium. As you see here, some of them like age and whether the patient is frail, there's not much we can do about. But how we manage the patient, how we treat the patient, what time of the day we do the blood draws, which medication we use, all of those factors are things that we probably should pay attention, and partnering with our colleagues in medicine and surgery will contribute to a benefit. The other reason we should care about it is because when you look at all comers, all patients who come into the hospital for the same condition, we notice that once you control for all the factors that normally we can, the patients who develop delirium do significantly worse than patients who had the same condition, are treated similarly, but do not develop delirium. And Heidi mentioned this before when we were talking about hypoactive delirium. I just want to point out that our colleagues in medicine, surgery, and trauma get really fancy and, in the high horse when the patient is agitated, pulling the line, taking the ECMO line, driver line out and things like that. And then they call us stat consult to the ICU. Those patients are exciting, but A, they're the minority of the patients, and B, patients who are not causing problem are the ones who do the worst of the worst of the worst. Also mentioned before, age, frailty, and baseline level of cognition. There's this reciprocal relationship, and in fact, I'm teaching a seminar that talks about delirium and dementia, two sides of the same coin, right? We know that cognitive impairment and dementia will lead to a higher incidence of delirium. But unfortunately, we also know that patients with delirium, patients who develop delirium will develop cognitive impairment. So they're both sides of the same coin, and they get augmented by the presence of frailty. We know that frailty and the degree of frailty will be one of the most significant predictors of delirium. So let's say that you are here, this is normal, and you're just below normal when you come to the hospital for your hip replacement, and then you get delirious, and you get down here. You get better, and then you get here. The problem is you didn't get exactly to where you were before. So now you start looking delirious, right? Sorry, you start looking demented because the degree of cognitive impairment, that gap has now breached itself and leads to worsening cognitive functioning, which now is going to make it more easier for you to develop delirium in the future. And the data also show us that patients who were experiencing cognitive decline, if they have an episode of delirium, it's like adding fuel to the fire, and that cognitive decline will accelerate at a rate that is twice as fast as what it was before. This is mostly data from Vanderbilt, actually, and it's fascinating because if you go to most medical centers and you look at all the patients, you see that about 50% of the beds are occupied by patients that are delirious, meaning those patients didn't leave the hospital and stay longer because they were delirious and they were not dischargeable. And then depending on the study, you see that each one of these have a different reference, but depending on the study that you're looking at, you see that death rates dramatically goes up on patients who are delirious. That's true also for the 90 and the 6-month mortality. And the other thing that I'd like to point out here is that the occurrence of delirium is bad, and we already talked about that. If you get delirious, you're more likely to have cognitive impairment and not to do as well. But the longer you are delirious, the worse the outcomes. So then the question here is, can we prevent delirium? And if we cannot prevent delirium, can we prevent the impact of delirium? So it only lasts 2 days instead of 5 days. And then can we treat delirium or reverse delirium? And I think that we all have been looking for that and kind of gotten stuck with it. Seventh, delirium is often missed. I mean, I remember meeting Wes, and I always felt like, you know, when you were in medical school and I was doing cardiology, and then the cardiologist will walk into the room with the stethoscope wrapped around the neck, and he will walk in and said, oh, it's an ST, you know, it's a S1 gallop and blah, blah, blah. And I'm like, how the hell did he do that? And then I met Wes, and then Wes will walk by the room and ask 3 questions and then delirious, and then you keep on going. I mean, you will think that we should do that. I mean, we are shrinks. We know about behavior. We read minds. You guys don't read minds? It's only my pathology. No, so, you know, and I'd like to think that I can go into a room and say, yes, the patient is delirious, and that will be the end of it. But, you know, the data does not suggest that. The data suggests that we, physicians, all of us, including psychiatrists, we suck. We just do. And there are many reasons why we're not so good, from how much time we spend to the patient, to our own biases, to the fact that there's a number of tools out there that we don't pay attention to and don't use. And in fact, it's not lack of tools, because when you look at this, you see the blue ones here is every new iteration of DSM. And then you look at the pink here, and it's every new tool that is created after each new iteration of DSM. So you see the CAM is here as a DSM-3, and CAM ICU is here as a DSM-4. I'm sorry, I don't have PCAM here. I only talk to adult people. I know. And then, of course, DSM-5 came out, and we came out with our own tool because I felt bad having a slide that didn't have my name on it. At least I'm honest. So now, really, like, why did we decide to look at a new possible tool? One is, I did want my name on the slide. But the second more important one, we have a new way of diagnosis, right? DSM-5 came out, ICD-11 came out, and I really wanted to know if the criteria has changed, should our tool change? But the other one has to do with this. Some of our colleagues have been doing meta-analysis, and there's data that suggests that some of the really, really good tools, CAM ICU, for example, is 100% sensitive and specific for the diagnosis of delirium when the patient has hyperactive delirium. But it doesn't seem to be, at least on the meta-analysis, as good as we would like it to when the patient has either hypoactive or mixed type delirium. And then when you look at the reality of things, this is, you know, our delirium picture. So the very agitated patient that you and I will probably walk into the room, patient who is hanging from the chandelier after biting the nurse's nose, you probably know the patient is delirious. But that only occurred in about 7% of the cases, right? The majority of the patients have this, the hypoactive type, which is about 70%, or the mixed type, which is kind of the balance. So then the question is, can we find a tool that is sort of like able to go through the spectrum? So we created a tool, and you know, you probably have seen some of these before. This is what it looks like. And the idea was this. I go into a patient's room and I spend somewhere between 5 to half an hour, 5 minutes to half an hour with the patient. The nurses are spending 12 hours with the patient. So we wanted to take and harness all the knowledge, all the experience that the nurses have. So then we created this questionnaire, and this is what the answering sheet looked like. And the way we did it is we took the data and then we wrote the questions to be as difficult as possible. So one of the questions is, does the patient have anosognosia? And then we did cognitive testing with the nurses. The nurses were in the room. We did that 12 times. And we have a camera in the back of the room. And said, does the patient have anosognosia? And the nurses would look at me and says, what the hell is that? So then I explained it to her, and then she said, well, if you were so smart, why don't you ask this way? So we are there writing it that way. And at the end, all the questions that we have were written by nurses. So now we have a tool that we use the criteria, but it was written by nurses for nurses. So the nurses are there 12 hours with the patient. And on the last 2 hours of their shift, they will do the tool. And as you see, it has three components. The first one is their VAS score. The second one is our speed. And the third one is something that differentiates between hyperactive, hypoactive, and mixed type delirium. So our study among general medical patients showed that we had sensitivity of about 80%, specificity of about 90%. And then we replicated the study, this time with general medically ill patients plus ICU patients. And as you see, we still had sensitivity of about 80% and a specificity of about 95%. And then we decided to look at the data and say, can we do any better? We started looking at all the patients we had done, and we look at factors that we thought about that, but we did not include. And once we added age, you see that it improved the sensitivity by 10 and the specificity by about 5%. Just adding something back, and we didn't have to do anything new because we had all those cases. All we need to do is look at the chart and see what happened. So then we created a new tool, we tested it, and then we translated it into Spanish, and this is the Spanish version of that. Some of the co-authors, I can see them in the room. And what you see here is that the sensitivity went up to 94%, and the specificity is about 97%. And one of the things that we are more impressed about is that if you look at the 13 components now, all of them seem to contribute almost equally to the final diagnosis of delirium. Hopefully one day in collaboration with Vanderbilt, we can create something similar for the pediatric population. Now, some of the people are coming with some various tools. In fact, Dr. Shinosaki is here in the audience, and he got the Caton Award, and he's going to be telling us about your tool, which is not this. This is the cerebral system, but he has an EEG-based system here. This is what it looks like. This is what it looks like on the patient's head. And the technology is not fully there, but we're getting there. When they started the original cohort, the first 50 patients, the sensitivity and specificity was around in the 50s. One of the things about the cerebral system, which I started to work with them about a year and a half ago, is that it's all AI-based. So what we're doing is we're training the computer based on the EEG and the result of the test. Who is delirious, who is not, which one is hyperactive, and which one is hypoactive. And this is like the partial data just from the Stanford cohort. One thing that I want you to notice, and this is what I want to discuss with you at lunch, is this. This is the data of the cerebral system validated against the CAM ICU, because we trained the machine on the CAM. And then I got added to the study and decided we're going to train the machine now against DSM-5. And as you see, it loses some sensitivity and specificity. The question there is it the operator, or is it that we just trained the machine on the wrong criteria to use? Now, I think that we all agree that they should all be validated against the same criteria. Since the CAM and the CAM ICU were validated against DSM, then eventually we need to get that up to speed. And there's a tool that I want to just bring to your attention. It's called PPRA. It stands for Pre-Surgical Prognostication for Post-Operative Delirium. It's a app-based. You can have it on your phone. You can put the 18 elements, and it would actually predict which patients are going to develop delirium later on. That is kind of the experimental phase. The real purpose of this machine or this AI technology is that it gets built into things like Epic. So when the patient is admitted to the hospital, it runs in the background and then gives you a flag and says, by the way, you should know your patient is at high risk of developing delirium. And then we can make decisions about treatment and so forth based on that. So, we're moving on the technology. The question is, how do we use the technology in the future? I think it's important when we think about delirium management that we understand that there are risk factors that we need to manage and prevent if we can. that we need to use tools. I mean, I think that that's the message today. We need to do surveillance of our patients. Otherwise, remember, most of the patients are the hypoactive delirium. And I know that, at least in my institution, the nurses kind of love patients with hypoactive delirium. They don't bother anybody. They don't try to extubate themselves. They don't even ask for ice cream in the middle of the night. They just don't do anything. And they only become a problem when they want to discharge the patient to the nursing home or the SNF, and they get rejected because the patient cannot even do 15 minutes of exercise. And that's a real problem, because those patients do the worst, right? And yet the agitated patient get all the attention. And then treatment. I think that Dr. Smith already pointed out, there's no one pharmacological medication to ever treat delirium, and there are many reasons for that. But there might be some strategies that we can use to manage the patient better, so less offensive than the alternative. I'm not going to speak much about non-pharmacological techniques, because you mentioned that, and I think Jesse is going to mention this. But I want to point out that there's absolutely no doubt that non-pharmacological techniques work. This is from Sharon Inoye's original study. She demonstrated that when you do all of the techniques from the health method, that you decrease the incidence of delirium by 40%. And from that, then you have the A to C protocol, which has already been mentioned. And the data suggests there's absolutely no doubt that the multi-component actually reduces the incidence of delirium. But the data also shows that it has no significant effect on the duration of the delirium, the mortality of these patients, or the eventual destination, with one exception, which is mobility. Getting the patient out of bed as early as possible is one of the main things. I was threatening to leave my hospital to go to another place to become the chair. And when I was negotiating with the hospital, the CEO of the hospital says, well, what can I do to keep you here? And I said, well, I need 5 more psychiatrists and about 20 more physical therapists. Because I just need my patients to get the hell out of bed. And that's why I have an order in my record that says, set the mattress on fire. I just want everybody out of bed. And we live in California. We have a beautiful $2 billion hospital, and it has 4 beautiful backyards or patios in the 3rd floor, and we don't use them. I want all my patients on there. In fact, I would like to have a coffee truck with my cappuccino ready for me, and the patients just filing by under the sun to see me. Now, because we cannot treat everybody that way, sometimes we need to use medications. And then the question is, which medication would be the best? I don't believe I'm saying that we're going to use an antipsychotic to treat delirium or pretty much any other medication. What I'd like to do is understand how the medications work to change brain chemistry, look at the patient's behavior, and try to understand that behavior is more likely associated with an excess of glutamate or an excess of dopamine or a deficiency of whatever. And then we kind of find the pharmacological combination that goes with that, right? So it's like if you're cooking, you don't throw anything there. It depends on what you want. You want it more salty, then you use salt. And that's what I want you guys to do. So, see, we didn't coordinate this, but I just want to point the same thing. No one pharmacological agent will be able to do everything. And I cannot spend the next 20 hours explaining all of this, so I'm just going to give you the highlights. Alpha-2s are great. I love alpha-2s. I wish we could use more alpha-2s more safely, but they also have their limitations. And there's a potential problems weaning people of them. One thing that I wanted to pay attention to is the selectivity of the agent might have a lot to do with how well we can use that agent, right? The least selective agents like clonidine, you will have more hypotension and more bradycardia. So you have to be more careful about using them. I know that we will get excited about that because that costs about $5 a day, and this costs about $1,500 today. Now, one thing I probably would like to highlight is there's a new medication called IGALMI. IGALMI is oral dextromethorphan. It comes in a little film, you put it in your mouth. It has 3 dots, and each dot has 60 micrograms. So you can put 1 dot, 2 dots, or all 3 dots. It has the same half-life, so about 2 hours. And we're doing now studies to try to use it to prevent putting people on DEX. But the other alternative would be, can we use it to DEX cycle? So the patient who doesn't need any DEX during the daytime, but giving them some DEX at nighttime and putting them to sleep in a more physiological manner would be one of them. You know most of this, so I'm going to go very quickly. I talked about, and Dr. Smith talked about the fact that the sleep caused by alpha-2s is more physiological than the sleep caused by some other medications. Now, some of the medications that we tend to use is sedative, because as sedative, they actually suppress REM cycle and therefore destroy the normal architecture of sleep. DEX doesn't seem to do that, so again, it might help with that. And the other thing is that I really love DEX for is that you get a twofer, right? So when you use an alpha-2, you decrease noradrenaline, but you also dramatically decrease glutamate. And when you think about glutamate being the #1 excitatory neurotransmitter in the brain, you decrease anxiety, agitation, and psychosis. All at the same time, you're helping the patient feel more calm and less anxious. And we did a study with the use of dexmedetomidine, showing for the first time a dramatic reduction. This is in alpha propofol and DEX. And since then, there have been a number of meta-analyses confirming that the use of alpha-2 agonists is very significant. We did a study using the little child of dexmedetomidine, guanfacine, which, by the way, I love guanfacine, with except for the fact that the half-life is too darn long. Just take too long to keep me. And I saw Dr. Yang somewhere in the audience. There he is. He just published a study using guanfacine on patients, demonstrating the same thing. Once you start people on guanfacine, you have a dramatic reduction on the use of sedative and medications that normally you would use for agitation. You just skip that just for the sake of time. And then antipsychotics. Dr. Smith talked about antipsychotics. Just want to point out, I mean, you are all trained. I know that you know that all antipsychotics are not created equal. You probably read the literature from our colleagues in critical care medicine. You know, Tim Girard, Wes Eli published this paper suggesting that Haldol, ciprastadone, and placebo had no effect on the incidence of delirium. That's the bottom line of the study. Now, some people have been concerned about that because, I mean, sometimes patients are agitated and you need to use something like haloperidol. The reason I would criticize a study like this is because in this study, the vast majority of the patients had hypoactive delirium. And most of us would have not used haloperidol or ciprastadone, especially at the doses they use for hypoactive delirium, because predictably the patient would have been more hypoactively delirious and therefore receive more medication perpetuating the cycle. Now, one great thing about this study is they demonstrated that you can give a truckload of Haldol and ciprastadone, and they did not kill anybody, nor did they cause QTC prolongation. So I love these guys because they are proving our point. Now, when you think about this, this is Haldol. This is the receptor binding profile of haloperidol, and this is ciprastadone. Why would you compare these two agents? I have no idea, except for the fact that they're both available IV and they're easily to, randomize. But when you look at this, we would not have expected them to work. And I always say that, if you're going to use an antipsychotic or any medication, please know what do they hit before you decide to use it, because that's the target. It's not an antipsychotic, it's your target. I'll send you a copy. These are all the drugs that, we consider in the antipsychotic family. The ones that are highlighted here, the only reason I have them there is because now that we are showing in the ICU and ECMO patients, we have the chronic sequestration, and these medications would not suffer that fate. Now, is there great data for the use of antipsychotics in management of delirium? No, the data is actually not that great, but the trends are pretty good. That's necro, that's cardiovascular. In fact, if you look at this study, according to this study, this is a negative study because patients, there was no difference on the incidence of delirium. But when you look at the secondary measures, they were less delirious, they were less agitated, and they recovered significantly faster, and they leave the ICU soon. And again, Larson, who used olanzapine, which I would have never used, Warren, and then Van der Bogart, and most of the meta-analysis have shown something similar. So I'm going to stop here because I want Dr. Alicia to be able to do some talking before we go for lunch. Thank you very much.
Perfect. That's great. Hi, everyone. So Jose thought he had a hard act to follow. And how about me? I have 15 minutes palliative care after 3 brilliant talks. So
It's lunch after this. They're not hungry.
yeah, of course. Yeah, exactly. We'll just keep on going. Hi, everyone. It's really a pleasure to be here. Thank you, Jose, for inviting me to join the symposium. I have no conflicts of interest to report. We're going to start out with some definitions here. A couple of weeks ago, a former fellow of ours emailed me about a chapter we had written. And his point is well taken. He said, Dr. Aledra, in your chapter, you never mentioned that palliative care starts from the beginning, at the time of the diagnosis, and it covers all the way through. And because when we talk about delirium in palliative care settings, we're not necessarily talking about a delirium through the disease trajectory, right? So when I talk about delirium in palliative care settings, I'm talking about delirium in the last weeks to months of life. And when I talk about terminal delirium today, I'm going to be talking about delirium in the last hours to days of life. It's also consistent with the literature. Okay, so I always like to include a case in the presentations, and this is a highly de-identified case of one of our patients. Jay is a 65-year-old metastatic prostate cancer. He's on home hospice. He's admitted to the hospital. It happens, right? Family says, we're not able to handle the patient, and then they come to the hospital with altered mental status. The medical team is unsure whether the delirium is due to disease progression or a reversible etiology. He's on low-dose oxycodone for pain that was recently increased due to worsening pain from his bone mets, and he's not on a lot of medications except he's on diphenhydramine. An initial workup reveals hypercalcemia, some new bone lesions. He's getting IV fluids, biphosphonate, low-dose morphine, and then low-dose haloperidol for agitation. He's severely agitated. Several hours later, his mental state gets worse, including bouts of severe agitation. He becomes paranoid. And then the family believes that the worsened mental status is from haloperidol. Familiar, right? Sounds familiar. Okay, so let's start out with some of the facts about delirium in palliative care settings. Matthew also showed this a nice systematic review on delirium in prevalence and incidence in different palliative care settings. As you can see, at the end of life, the rates of delirium is much higher. At the time of admission, at least 1/3 of patients are diagnosed with delirium, and in the terminal stages, the rates go all the way up to 90%. Okay. My age will reveal here. I have to take off my glasses. So we know that delirium can interfere with assessment and management of symptoms such as pain. What does that mean? One, it may mean that pain can trigger delirium. That may be the reason for delirium. And then you have to give patients more opioids or do an opioid rotation. But it could also mean that patients with delirium express their symptoms differently because of all the disinhibition and disturbed higher level of higher cortical functioning. This is a very nice study that looked at patients who were admitted to a palliative care unit and their ESSA scores, that's the Edmonton Symptom Assessment Scale that palliative care physicians frequently use, and how that changed through the course of their hospital stay, and compared those who developed delirium versus those who did not develop delirium. And many of the more comorbidity and all were equivalent between the two groups. Interestingly, as you can see here, I'm not doing a good job pointing. You can see the cursor here. No, I have to use the other one. So if you look at right here, this is patients with no delirium and how their symptoms improve as they receive treatments. But if you look at the patients with delirium group, if you look at the changes, this is the change in their SS scores from admission to later in their hospital stay, their symptoms do not improve. And they're also getting the treatment, they're getting pain management, they're getting anxiety management, nausea management. They're not improving because delirium interferes with assessment of symptoms. One can also say if a patient is delirious, they're sicker. This study says they were similarly equally sick. However, I think the important point here is when we are monitoring delirium, we should also be monitoring for other symptoms, right? I tell our fellows, please fill out your review of systems, right? We have to make sure that we're assessing for other symptoms and not just for delirium, because in all reality, patients with intractable symptoms could be delirious, and their treatment may not necessarily include further escalation of their opioids, but it could be just the rotation of their opioids. Okay, so delirium is a harbinger of impending death, as increased mortality studies were reviewed by other panelists. In the terminally ill, it's a really reliable predictor of approaching death. And as mentioned before, hypoactive delirium, irreversible etiologies, and greater cognitive impairment are most predictive of death in the last days to weeks of life. Now, interestingly, this is a study that was done by one of our former fellows, where he looked at not just palliative care units or hospices, but he looked at like anywhere in the hospital where death was occurring. And it turns out if you look at the delirium rates, the middle column, in this table, well, wherever death is, delirium is, right? So we're not leaving this world without delirium, and we have to be paying attention to patients on all the floors of our hospital. Distress studies have been many, and they have been replicated since this initial study by Breitbart and colleagues. We know that patients remember being delirious. More than 90% who remember delirious reported as being distressing. It's most distressing when it's severe and when there are delusions and hallucinations. And interestingly, hypoactive is just as distressing as hyperactive delirium. And interestingly, again, caregivers, family caregivers are most distressed by hypoactive delirium. So the rest of the clinical team may not be as distressed, but families, patients themselves are highly distressed. Now, an interesting study, again, thinking about the experiences of caregivers, patients, and families of delirium, the systematic review looked at qualitative data on the experience on delirium. And it was interesting that the study had the systematic review had three main findings. One, the limiting understanding about delirium makes it actually much more stressful. So if we have a limited understanding of delirium, instead of focusing on prevention, early identification, modification of possible causes, we're going to focus on the symptom management, right? And we're going to miss the boat because there's going to be a lot of patients who are going to be developing delirium. The person-centered care is important, but it's difficult to accomplish in delirium in the terminally ill because most of these patients may not necessarily be engaged in their own care. And finally, at times, use of medications may be triggered by families and clinicians' distress and limited resources, as Heidi mentioned so eloquently. So despite its significance, as Jose showed you a number of different studies, it's significantly under-recognized and misdiagnosed. Now, in the palliative care literature, the misdiagnosis rates range from 30 to 60%. And interestingly, patients with missed delirium are frequently referred for pain. So what does that mean? Again, these patients are likely to receive escalating doses of opioids. Think about that study that looked at how opioids were more likely to cause delirium than any other medications. So those are really the patients that we need to identify and manage. So it's not that we're all bad clinicians, right? There's certain reasons why we miss delirium. Now, this is about a 15 years old study now, but David Meyer and colleagues from Ireland looked at the frequency of symptoms of delirium. And if you look at the present at any severity, the first column, sleep-wake cycle disturbances, attention, very common, 97%. Look at orientation, 76%. Now, how many times any clinician will go into the room and only ask orientation questions to then leave the room and think that patient is not delirious because they're missing these 24% of patients who are fully oriented despite being delirious. And then those patients hanging out of the chandeliers, they're probably only 50 to 31%, right? Those are patients with perceptual disturbances, delusions. The ones with motor retardation, that's 62%, those are the ones that we're going to be missing. And then the other thing is, it really gets confusing, right? We have subtypes of delirium in the palliative care setting. Hypoactive subtype is also most common, and for not for our psychiatry colleagues, but for non-psychiatrists, except for Heidi, we would like to highlight that hyperactive delirium not only causes delusions and perceptual disturbances, but you can also see that in hypoactive delirium. So those patients that we're not medicating, we're so proud, we're not using antipsychotics for them, they may be silently hallucinating and feeling paranoid. And mortality is higher for hypoactive than hyperactive delirium. So screening, we have to screen for delirium. So guess what? There was a nice survey study that looked at the percentages of clinicians who were doing the screening. And you see the results here. Most clinicians, or half of clinicians, said they just use clinical judgment to screen and diagnose delirium. And some of them only screen in response to clinical symptoms. Routine screening on admission was about 5% of respondents. Daily screening, 6%. There was no training in 60% of clinicians' responses, and there were only clinical delirium guidelines based on the responses from 1/3 of physicians. Now, I have to tell you that in my institution, we do daily delirium screening on all patients once a day. We have delirium guidelines. I'm embarrassed to report to you that the accuracy of our delirium screening scores are really low. So unless we continue to do training, we continue to lean in, educate our non-psychiatry clinicians, it's going to be a lot of difficulty in diagnosing delirium. This is just different screening tools. Dr. Maldonado already showed them. Yours is not here yet. It will probably be in the next systematic review. I'm just going to make a pitch for Memorial Delirium Assessment Scale. We use it a lot in our institution. That's not the one that's used for daily screening. Psychiatry service uses it mainly to assess for symptom severity from day to day and really to adjust dosing of the medications that we use when we use them. Okay, I'm going to fly through these. So the point I'd like to make here, it's an interesting meta-analysis that was done in the palliative care settings. If you think about risk factors, we all want to focus on the modifiable risk factors because those are the ones that we can do something about by use of non-pharmacological measures. Now, all good and great, but if you look at the third bullet point, actually only one study was able to show those modifiable risk factors being strongly related to delirium in palliative care settings. It doesn't mean that we shouldn't do everything that we can, and we should. The data from general hospital settings, ICU settings, it's all great. I think in palliative care settings, right, there's something that happens. So in addition to doing all the non-pharmacological measures, there are times that we may need to use medications. So the assessment, all the testing that we do, it's really dictated by treatments, by goals of the patient. It has to be minimally invasive and terminally ill and not burdensome or distressing. We have 2 minutes. What do you suggest? Just keep going? Okay. So this is a nice review paper by Dr. Agar from Australia, and really helping clinicians in terms of what are the potential benefits of doing an extensive workup or a workup that can identify reversible etiologies, and what are the potential harms. So even in palliative care settings, delirium can be reversible. Depending on the study you look, the reversibility has been about 20 to 50%. So that's a lot, right? A lot of patients may actually be more awake and alert towards the end of life, despite ongoing dying process. So reversibility is mainly when medications, electrolyte disturbances, and infections are the cause. And if it's a major organ failure or hypoxia, or if delirium was previously experienced, then the delirium may not be reversible. Now, I want to highlight this delirium previously experienced. We heard about the long-term cognitive impairment due to delirium, long-term effects of delirium. This is what it is, right? Where patients are more likely to have irreversible delirium. This is a slide that Dr. Breitbart uses in all his delirium talks, but it really highlights the fact that if you think about delirium at the last hours to days of life as terminal delirium, and any other delirium as pre-terminal delirium, right? Your aim at the end of the day is you're trying to prevent or reversing the etiology, you're controlling the symptoms, and then your outcome might be reversible or irreversible, right? 20, 50%, that's a lot of patients with reversible delirium. This is where I'm gonna skip through this. You can read it later on. Now, this is actually a nice paper. The Gagnon reference here is only in reference to one of the studies here. It's a paper by Shirley Bush. It basically makes the argument that even in palliative care settings, the non-pharmacological interventions are feasible. And we should use probably different outcome measures in the palliative care settings to be able to make the argument that these are also effective treatments and should be used in the palliative care settings. So far, there's only one study that looked at non-pharmacological interventions in palliative care settings. That was a negative study. Okay, so moving on to pharmacological trials. So this is the seminal study, 1996, Dr. Breitbart conducted in AIDS patients. It was 30 patients total. In each arm, haloperidol, chlorpromazine, lorazepam. In each arm, there were about 7 to 10 patients. Lorazepam arm was discontinued early because patients were doing much worse. But then the patients on the haloperidol chlorpromazine arm experienced improvement in their delirium symptoms. So this study actually was the only study that dictated our practice in the palliative care settings for many years. 2017 was one of the best designed studies that came out looking at the use of oral risperidone, haloperidol, and placebo in palliative care settings. Now, the design of the study, wonderful. The problems with the study are, so basically, let me just say this. So the study did not show any difference between the 3 arms. As a matter of fact, maybe patients who took risperidone or haloperidol did a little bit worse, but that was really about it. Now, the problem with the study was most of the patients were kind of like mildly delirious. They use the MDAS for delirium screening, and then the highest MDAS is 30. Patients in the study were like 9 to 13, so they were like barely delirious. And then the dosing of the medications used were like 1/4 milligram to 1/2 milligram, so really ginger dosing. So the findings are not surprising, but the other thing is the outcome measures were not the typical outcome measures that have been studied before. But I think it's important to know the study really well, because family members will bring this to you and it will say, well, you're using haloperidol and look, this is what the evidence says. And then finally, the study completed by David Thuya and colleagues in the palliative care settings, use of lorazepam one-time dosing with haloperidol versus haloperidol alone, showed that patients on haloperidol with lorazepam did much better in terms of reduction in their RASS scores. So reduction in the RASS scores is not a typical delirium outcome, but in the terminally ill patients, that the study group felt like it was a reasonable outcome. That was actually a real life outcome. They used 2 milligrams of haloperidol in each arm, and then 3 milligrams of lorazepam on top. But let's admit, patients were probably sedated, right? And then the same group did another study where they looked at haloperidol, chlorpromazine, and then a haloperidol combined chlorpromazine arm. Again, the RASS scores both decreased. So it was again another double-blind trial, randomized trial. But at the very least, the patient's RASS scores were reduced, their agitation was reduced, they looked comfortable. So in the terminally ill, I think those 2 last studies that I mentioned are further evidence that those medications can be used. I love these debate articles, and I highly encourage you to read these 2 articles. One is Meyer-Ager, and then the other one is Meyer-Ager and David Tui and Dr. Maeda. They talk about the use of antipsychotics from really, they argue for and against in the most beautiful way, but at the end of the day, they're all saying the same thing. Like, use them judiciously, use them carefully, know your antipsychotics. So I think it's those articles I find helpful in talking to to patients and family members. So Jose, dexmedetomidine in palliative care settings. So there's actually a lot of evidence coming out for use of dexmedetomidine in palliative care settings in the terminally ill. And as you can imagine, if it can help patients stay easily arousable and calm, then hey, that's a great drug. Obviously, you can't use it in the home settings. You cannot use it in regular floors, at least as it stands. And there are not that many studies about it. There's like a retrospective study that showed that it really helped the pain, helped the delirium at the beginning, but not so much after several days of use. And then there's an open label trial that looked at 0.3 to 0.6 milligram kilogram hour ratings of the dexmedetomidine, which patients actually did well in terms of their delirium ratings. The only thing is half of the patients in the study, it's not a large study, it's 22 patients, half of the patients in the study had to be crossed over to had to be taken taken away from the study per the family request. It's not really clear why that family request was. Maybe they were too calm, I don't know. Okay, so no palliative care talk should be without palliative sedation. We know that palliative sedation is an intervention. It's a medical intervention that's used to treat refractory symptoms, to relieve suffering at the end of life. There's a ton of debate about it out there. There's a significant amount of variation in the way different institutions do this, the frequency of doing it, different protocols out there. You can't even find what the prevalence of it is, especially in the USA. Most of the literature is from Europe, but it's about 10 to 30%. And interestingly, delirium happens to be one of the it's the second cause of why palliative sedation is considered after dyspnea. Pain is third. For existential distress, it's debatable. It's a different talk. Different medications are used, including benzos, different antipsychotics, and propofol. I'm not going to spend a lot of time here, but there's even studies that looked at palliative sedation at home to relieve symptoms. This is important knowledge. In a Cochrane review that looked at all the palliative sedation papers show that patients who underwent palliative sedation did not experience hastening of their death. I think that's one of the main fears, right? As long as you use proportionate palliative sedation, not a palliative sedation to unconsciousness, if you use proportionate palliative sedation, then it doesn't hasten death. Okay, some nice statements in the prevention, as I said, non-pharmacological tries. Okay, so back to the case, what happened with this case? So what actually ended up happening was the team had to call an ethics consult. So the ethics consultants came, and then basically it was determined in discussions with family, clinicians, interdisciplinary team that we have an obligation as clinicians to reduce patient suffering, to alleviate patient suffering, and therefore we're going to continue to use judicious amounts of antipsychotics, and patient peacefully passed away. unfortunately in the hospital. So hope is on the way. I think for you've gotten this from all the talks, but in palliative care, right, from 10 studies a year, now it's about 80 to 100 studies a year on delirium and palliative care settings. And so that's good. And there's increased interest in the delirium about how we should be doing the delirium studies in the palliative care setting so we can have better quality studies. Okay, just wanted to end with this. I'm so proud of this article that I wrote when I was a really young fellow. It's like a CL psychiatry fellow. It's still, I think, it's still a good teaching tool from 2008. It kind of talks about management of delirium and palliative care settings. But what I want to say to trainees in the room is, where you start is really important. And if you continue with it, if you love it, you continue with it, it gets you to good places. And then finally, a pitch to this nice book that several of us have contributed that talks more about delirium and palliative care settings. I thank you. And I apologize, I kept the additional